Instead I hear the clock ticking, think of you, I'm caught up in circles. Confusion is nothing new. Flashback to worn out, all those left behind. A suitcase of memories, time after sometimes you picture me walking too far ahead. You're calling to me, I can't hear what you said. You said it also.
So this afternoon then, so we kind of did an overview of dementia this morning, focused mostly on capacity in the second hour. In this next hour and a half or so, we're going to talk about another question I commonly get asked is, why don't you just drug them so they'll stop, right? So we're going to answer why we don't just drug them so they'll stop. That's kind of like the whole thing. And then after that, we'll talk about alcohol. Disclosures are that. So a couple of disclosures are. Let's see here. So one is that the focus of this talk is pharmacological interventions for dementia-related behavioral disturbances. Every medication that I'm about to talk about would be used in an off-label way. There is no medication that is FDA approved for dementia-related behavioral disturbances. None. So anytime we treat these behaviors, we're using medications in a way that they were not approved by the FDA to be used, right? So they might be approved by the FDA for use with schizophrenia or bipolar disorder, for example, but they were not approved by the FDA specifically for this. So we're doing it in an off-label way. Because medications, I always throw my wife up there as a disclosure. She's a private practice child psychiatrist. And so she does, as a function of her job, she does a lot of work with industry-sponsored clinical trials. So there's contracts between her and industry, Pfizer, Eli Lilly, whoever. So any and I never know what clinical study she's doing at the time. So I always just tell the audience, just assume that if I mention a medication, chances are she's contracted with the company to do something with that medication. I don't know what it would be. Just assume that. And then the other, not so much disclosure, but point of emphasis is that we're talking about pharmacological interventions for these behavioral problems. However, we always start with non-pharmacological interventions first, right? So we don't go to medications until we're convinced that the patient has failed non-pharmacological interventions first. Okay. That being said, we'll talk about kind of epidemiology of these behavioral problems, the pharmacological treatments for them based on the gold standard clinical trial, double-blind, randomized, placebo-controlled clinical trials, and then we'll talk about the general pharmacological and non-pharmacological recommendations for how to handle these problem behaviors. Another day in the life of maintenance. All right. Get off my porch. All right. So we'll begin with that. So when we begin with epidemiology, I think it's important to know what are the behaviors that I'm talking about, and how are these behaviors being measured in the clinical studies. And so probably the most commonly used instrument for measuring these behaviors is called the NPI, the Neuropsychiatric Report. And so this is a caregiver, this is a proxy reported questionnaire. So the the examiner is asking the caregiver about their loved one's problem behaviors. And it measures, this instrument measures different neuropsych domains. So it's looking at delusions, hallucinations, depression, all the stuff that you see on the screen here. The one that we are focused on today for this hour really is the delusions, the hallucinations, and the agitation and the aggression. And it's really the agitation and the aggression that we're focusing on right now. And so if you look at how, how is this still, how is it measured? So this is the MPI question right here. What you do, what the examiner does is he asks the care provider, which could be a wife or a husband, could be a spouse, an adult child, whomever. Does the patient have periods when they refuse to cooperate or won't let people help them? Are they hard to handle? And you just throw that question out there. Are they hard to handle? And if the answer is yes, then it prompts a whole series of other questions. So then the examiner says, okay, well, does your loved one, do they get upset when people are trying to care for them? Are they stubborn? Are they uncooperative? Do they curse? Do they shout? Do they hit? That kind of thing. Do they attempt to hurt or hit others? And what the examiner is doing by asking these questions is he or she is really educating the care provider on sort of the range of agitated behaviors. So they're just kind of planting the seed in the care provider's mind, the whole range of agitated behaviors. And then they'll answer those questions. And then the real question is, how often do these behaviors occur? And then how severe are they? And under severity, if it's mild, they're managed with redirection, reassurance, all the way to severe, where the care provider says that I usually have to give them medications to get the behaviors under control. So the way this is scored is you just take the frequency score, and you multiply it by the severity score, and that gives you the overall score. So as we go through all these studies that I'm about to show you, it's important to know how agitation is being measured, and then you in your own mind can decide, is this the best way, is there a better way, that kind of thing. If you look at the prevalence of agitation in elders with dementia, probably the best study, certainly most known, probably the best study that's been done, it's called the Cache County study. So Cache County is this little county in northern Utah, right, where they gathered a cohort of elders with dementia, 408 elders with dementia in this northern Utah county, and they administered the NPI essentially every year and a half for 5 or 6 years. They administered the NPI, trying to learn the prevalence of different dementia-related behavioral problems. So already, you can appreciate that a limitation of this study is, how well does the population of northern Utah, how well does that generalize to our population here in San Antonio, right? So we got, maybe not at all, right? It's very different demographics, one would conclude. So that is certainly a limitation. Nonetheless, what you can see is that the average age of their demented sample is about, what is that? If you combine it, it's about 82. They divided the sample up into those who they weren't able to do follow-up appointments with, and those that had at least one follow-up appointment. It's easy, the average age is about, about 83 or so. Over half of them had Alzheimer's disease. Nearly a quarter of them were on psychotropic treatments. So right now, what I want you to appreciate is that although, I'm telling you that any medication you use for dementia-related behavioral problems is off-label, it's prescribed off-label, it's still a very, it's a common off-label practice, right? So a quarter of their demented patients were on psychotropic medications. And within this group, you can see that a small number are actually on the medications that are FDA approved, in this case for Alzheimer's disease. Only about 8%, I'm sorry, only about 6% are on the FDA approved medications, which means that the other 20% or so of the medications are going to be antipsychotics, mood stabilizers, antidepressants, which again would be prescribed in off-label. So these medications are commonly prescribed. You actually look at the prevalence of agitated, or I'm sorry, behavioral disturbances. What you can see is that in this group in Utah, you can see that about 15% of the sample has delusions, about 10% or so have hallucinations. Going to agitation, which is what we're looking at, it's about 15%. If you kind of combine those two, about 15% have agitation. The most common behavioral problem would be depression, which would be about 30%. About 30% of this sample had depression. Apathy is a big problem, 20%. And you can just kind of look at the other symptoms that show up. So medications are widely prescribed for elders with dementia in an off-label way. And the behaviors, the irritability, the agitation, the delusions, the psychosis, this is a common problem, right? I mean, 15%, that's a common enough problem. So 15 to 20% are having these behaviors. So we'll talk about different pharmacotherapeutic strategies for dementia-related agitation. Again, when a family brings their loved one to our clinic, and they're telling us that their loved one, is striking out at them, or they try and bathe them, or they're wandering all over the house at night, or they're having delusions and they're accusing everybody of stealing their stuff, whatever it is. The first thing that we always do is try and figure out, is there an underlying cause for these behaviors? So what are common underlying causes of dementia-related agitation that we might be able to treat and resolve? Yeah, it's like polypharmacy, right, or drug-drug interaction. So maybe they're just on a slew of medications that's kind of making them loopy, and that loopiness kind of expresses itself in agitation. So polypharmacy, absolutely.
I have a physical elevate the agitation, if they're correcting someone.
Yeah. So there's things that family members can do, and I'm sure family members can certainly contribute to their loved one's agitation. My wife contributes to mine, but I think this is damn it, I'm on film. I think by and large, though, most family members, while they may not be able to, while they may be struggling to control the behavior, it's rare that they're the actual cause of it per se, at least in the patients that I see. And then you can also think about, like, in nursing home settings, that sort of deal. Again, it certainly is possible for the nurses or the nurses' aides to be the cause of the agitation.
Well, I think in terms of if I've seen where, especially if there's someone who believes that maybe they're, 20 years old again and they want to go to work, and you want family to tell you don't work anymore, and you can't go, or you can't. So it seems to elevate, or like in a nursing facility, when someone wants to walk around, or it's those kind of reactions tend to elevate.
Yeah, right. So they shout out, "Look, you retired 20 years ago. Sit down and turn on the TV." Well, that could lead to agitation. So yeah, absolutely.
You have underlying medical issues like urinary tract infections, or they might have pneumonia, or they might have, they're sick.
That's right. So underlying medical conditions, absolutely. And as you stated, without a doubt, urinary tract infection is what we're always ruling out, right? It would be terrible to put someone, who has a urinary tract infection on Risperidone when, what they really need is an antibiotic, like back trouble or whatever. That would be really important for them. So absolutely underlying medical conditions. Similar to underlying medical conditions, maybe the same thing, is also pain, right? So if there's chronic pain, so if we can get their pain under control, then maybe we can help with the agitation. So again, when someone comes in with an agitated loved one, we don't just jump on pharmacotherapy. We try and figure out what could be causing the agitation, fix that, and then we also work with them in providing reassurance and redirection if that can do the trick. Other non-pharmacological interventions before we jump on medications. Nonetheless, for this talk, it's focused on pharmacotherapy, and so that's what we're going to
You think environmental changes cause some
Yeah.
environmental changes?
Yeah, can lead to agitated states. Yeah, or resolve agitated states. Yeah, they could go either way, right? Sometimes it makes it worse, sometimes it makes it better. Yeah, absolutely. So we'll start with antidepressants. So the way antidepressants work is the way most antidepressants work is they increase a chemical in the brain called serotonin. Right? Most of the modern antidepressants are serotonin reuptake inhibitors, which means that they're blocking the channels on the nerve cell that suck the serotonin back into the nerve cell, leaving serotonin out in the cleft to act on the synapse. So antidepressants work on this chemical called serotonin. They increase the levels of serotonin in the brain. So there have been 5 randomized controlled studies with using antidepressants. So these are medicines like the ones that have been studied are fluoxetine, which is Prozac, trazodone, does a little bit. People know it's trazodone. Sertraline is Zoloft, and Citalopram is Celexa. These are the only antidepressants that have been looked at in a double-blind randomized placebo-controlled studies to see if they might have any benefit for these problems. Of the randomized controlled studies, 2 report modest benefits, and 2 that had benefit were Sertraline, which is Zoloft, and Citalopram, which is Celexa. If you look at the Citalopram study, so I'll start to walk you through these studies and the data, and I'll discourage you with it. So with the Citalopram study, it was done on inpatients. So this is done on all of the people in the study were psychiatry inpatients. So it's not an ambulatory clinic setting, it's psychiatry inpatients. So what they did was they randomized about 30 subjects to either Citalopram, the antidepressant, perphenazine, which is an old generation, never prescribed anymore, antipsychotic medication, or placebo. You can see that the average age of the sample is about 80. The average mini-mental exam score is about 7 or so. That's really low. Okay, so this is a severely demented population. You can see that the majority have Alzheimer's disease. And then the one randomization stat to really look at here is the dropout rate. The dropout rate is about 50%. So half of the subjects randomized to one of these 3 drugs dropped out of the study. The dropout rates in all of these studies are huge. The dropout rates are always huge. How do you drop out? Yeah. So this is all done through proxy consent. And what happens is that the proxy consent, there's 2 things that are happening. They're either saying, look, my loved one is having side effects, and I don't want them to continue to take whatever the study drug is. Or they say, my God, these behaviors aren't getting any better. You're telling me there's a chance they could be on placebo. I want you to pull them off and put them on something that I know they're taking, right? And so it's the proxy that is pulling them out of the study. Yeah. And of course, even though this is a locked psych inpatient unit with an incapacitated sample, the subjects have to assent, right? So there's a difference between consent and assent. They have to assent. So if the subjects just say, I'm not going to swallow those pills, well, they're not going to hold them down and put pills in their mouths or anything like that. You know? So there is an element of voluntariness to it. Okay. So when you look at the data, this study only lasted 17 days, right? So half of the subjects couldn't even tolerate a 17-day study, right? I mean, that's crazy, right? It's only 17 days. The other thing that you'll see, so if you look at agitation, what you'll see is that the citalopram group does statistically separate from placebo. So citalopram is purple, placebo is the green bar. You can see that there is a statistical difference there. However, if you look at the real numbers here, this is mean improvement from baseline, so they improved this group improved a point, the placebo group improved 0.4 points. There's only 0.6 points improvement on a 7-point scale. So although this is statistically significant, it may not be clinically significant, right? So the numbers may be saying, yeah, there's a difference here. It's separated from placebo. But through a clinician's eyes, or the patients or the families, you may not really see it. So again, it does show that citalopram was helpful, but it's not really exciting. No one gets excited. If you look at Zoloft or Sertraline, you'll see the same. The difference in the Zoloft study is that this is an outpatient study. So these are ambulatory patients, it's not inpatient. They're randomizing about 124 to Zoloft, 120 to placebo. And you can see at week 12, there's about a 0.3, say, difference on a 7-point scale again, right? So you can say statistically that there's a difference, but again, 0.3 point difference on a 7-point scale, is that really a difference that anybody can appreciate, without the use of statistics? Maybe not. There have been studies that have looked at citalopram, again, the antidepressant versus risperidone, which is an antipsychotic. And so this is one, comparing an antidepressant with an antipsychotic. Again, it's an inpatient sample. The mini-mental scores are terrible. They're 10. The dropout rates are huge, at about 55%. And at the end of their 12-week study, there was no difference between citalopram, the antidepressant, versus risperidone, the antipsychotic. They're both performing the same. This isn't placebo-controlled, so we don't know really if there's meaningful difference at all. But nonetheless, what we know is that citalopram seems as effective as risperidone for agitation in this So antidepressants, when you look at antidepressants, there's evidence that they help. Maybe. Probably the best case for antidepressants, though, is that they have the fewest side effects. So if you want to start with something and you don't want them to have a lot of side effects, and you want to kind of do the least harmful thing first, then you would start with an antidepressant because although it may not be any better than anything else, they certainly have more favorable side effect profiles. Sometimes people will say, well, look, dementia, agitation and dementia, it's kind of bipolar-like, right? They're irritable, and they're impulsive, and they're disinhibited, and they're, up all night wandering around, they're not sleeping. So it's not, agitation is not really like depression, it's more like bipolar. And so, so maybe medications used for bipolar disorder would be more helpful. So medications used for bipolar include Depakote, which is valproic acid, carbamazepine, Tegretol, or lithium, perhaps, right? And so, again, when you look at the data, though, there have been 5 studies looking at mood stabilizers, and the data is consistently disappointing. There was only one small study with carbamazepine that showed any evidence of benefit. Yeah.
You know, I'm wondering if part of the issue is that you're trying to treat people that are not psychotic. They have those types of behaviors,
Right.
but it's related to something totally different. They're not mentally ill.
Right,
And
that's
so-
the whole problem.
Yeah.
That is the problem, which is why these medications, so take valproic acid, for example, you know, it is approved for bipolar disorder. It clearly helps people with bipolar disorder. And then what happens is that with these dementia problems, they say, well, it has a bipolar flavor.
Right.
But it's not bipolar
It's not
disorder.
bipolar.
But they try it just to see if it might help. I mean, that is the whole problem.
Those medicines have terrible side effects.
Yeah, they do. They all have terrible side effects. So, you know, but, I mean, the worst side effects are that they're teratogenic, but and they cause neural tube effects in unborn. But you know, these patients aren't reproductive anymore, so yeah, that's good, I guess. Let's see what else. Yeah, you know, I can tell you, you know, anecdotally, the one medication that we'll use anecdotally is carbamazepine. So with carbamazepine, which is Tegretol, what it's good for, it's good for the patients who get on repetitive cycles and they can't stop the repetitive cycle. So for example, you know, if you go over, I can tell you right now, in the VA somewhere, there is an elder patient on a medicine service. And that elder patient on a medicine service is in his room and he's doing this. He's going, help me, help me, help me, help me. And he just keeps going and going and going. And then the nurse will come in and say, sir, how can I help you? And he'll say, huh? Right? And then she'll say, okay. And then away goes the nurse, and then the cycle just comes up again. Help me, help me, help me. So when patients get stuck in these repetitive cycles and they can't break out of them, that's a very thalamic behavior. These behaviors are mediated by a part of your brain called the thalamus, a very friendly part. So carbamazepine targets the thalamus, as it turns out, and so it can stamp those behaviors out. So that's about the only time we ever use mood stabilizers ever. What happened when antipsychotics got their black box warning, which we'll talk about, a lot of physicians moved over to prescribing the mood stabilizers, but they just don't help. So we can talk about, well, what about the medications that are FDA approved for Alzheimer's disease? What about the acetylcholinesterase? You know, again, there have been 6 randomized controlled studies. 3 of them show benefit, but again, the benefits, potential benefits are always small. You know, it's always, really? Is it really helping them? And again, they can always show statistical separation, but we're never convinced that there's really a clinical difference. So the only exception with the acetylcholinesterase inhibitors, again, anecdotally, is that they really do seem to help patients with Lewy body dementia. So if someone has Lewy body dementia and they're having these behavioral disturbances, acetylcholinesterase inhibitors can really help. However, they don't seem to help people with Alzheimer's disease or other types of dementia. Okay, so that brings us to the antipsychotics, which is the controversy. So the antipsychotics, the atypical antipsychotics, have the most data behind them. So there have been 11 randomized controlled trials with atypical antipsychotics. Almost all of them, there's one, the NIH funded one, excuse me, was ambulatory. But all the others are nursing home samples. So all of these studies were conducted in patients already in nursing homes. And then 6 of them report improvement with agitation, olanzapine, risperidone, aripiprazole, quetiapine. So already right now you know that if, you know, the class of medications that has the most studies, most data to support them are the atypical antipsychotics, not the antidepressants, not the mood stabilizers. How come? Why have there been more studies with atypical antipsychotics than the other classes of meds?
Is it higher risk? I mean, I would think there's increased confusion maybe and other things that occur because of this. I don't know.
No, it's not a risk thing. These medications have much more risk.
That's what I'm saying, they're studying.
Oh,
it
because
more
they're higher
because-
risk, they study them more?
Right.
Nah,
No.
that's a good thought. That's
I
not
don't
it.
know.
What's there a government program?
Money, in what way?
Oh, they're more expensive.
Yeah, so it is money. You're right. So all of these medications, the atypical antipsychotics, when all of these studies were being done, they're under patent, right? Because they're under patent, only the company can sell and can market and sell the medication. So because they're under patent, if they can get an FDA-approved indication for something else, then it can extend the patent, and the company can continue to make a lot of money. So how much, if someone's on Zyprexa, which is an antipsychotic, how much does 20 milligrams would be about a middle dose of Zyprexa. How much is a 30-day supply of olanzapine, which is Zyprexa? How much is a 30-day supply of Zyprexa? Do you know? Yeah, it's about $600, right? And so a 30-day supply is about $600. So you can imagine, so there's a lot of money to be made here. Whereas, all of the antidepressants are generic, right? Citalopram is generic, Sertraline is generic. So there's no money to be made. Trazidone's been generic forever. So there's no money to be made studying the mood stabilizers or the antidepressants. But there was money to be made within the antipsychotics. And perhaps also they're studied more because maybe they possibly have more benefits. But you'll have to judge for yourself if that's true. Okay, so if we start to look at the data for the antipsychotics, the medication that has been studied the most within this class is Risperidone or Risperidone. So Risperidone has more data, more studies looking at it than others. If you pool all this data together, there have been 722 subjects randomized to Risperidone, 428 to placebo. Again, the mini-mental is terrible, 7, right, which is really bad. About 30% randomized to, in these trials, drop out. So again, another huge dropout rate. However, if you carry the study out about 12 weeks, you'll see separation from placebo. So you'll see that Risperidone does separate from placebo again and again. And so that's the Risperidone. If you start to look at side effects, kind of speaking to your point about potential risks or how it matches up to benefits, you'll see that about the same risk of falls between placebo and Risperidone. Risperidone is certainly more sedating. A little bit more side effects related to muscle stiffness and muscle tightness and Parkinson's things. And then down here, what you'll see is a small number, 3.9% versus 1.6%. But nonetheless, it's higher for stroke, cerebrovascular accidents or stroke. So study after study after study that I'm about to show you, you'll see two things will always pop up. What you'll see is that the risk of stroke or death in the antipsychotic group is always going to be about 4%. And the risk of stroke or death in the placebo group is always going to be about 2%. So just kind of hold those numbers in here, 2% and 4%. That'll come up again and again.
Can you tell me why you said you kind of focused on 12-week study as opposed to a longer period of time? Because if it's separated at 12 weeks, wouldn't the separation be bigger at a longer period of time?
Maybe. It's just hard to do these studies. It's incredible. And we'll talk about that. The NIH tried to do a 36-week study. And I'll show you the results. So maybe, but 12 weeks is better than 17 days. Right? Okay. So olanzapine is Zyprexa. Again, looking at a typical study for olanzapine. 206 nursing home residents. With olanzapine, you know, it comes in 5 milligrams, 10 milligrams, 15 milligrams, 20 milligram strengths. So, you know, again, what you can see is the dropout rates continue to be huge. About 24% of the placebo. A little bit less if they're treated with 5, but then as you start to go up, especially up to the higher doses, you definitely get more dropouts with Zyprexa or olanzapine. If you look at the benefits, you can see that the placebo group improves by 2 points on this NPI scale, and the treatment group improves about 4 points. So that's better. However, as you keep going up on the dose to 15 milligrams, you no longer get any real difference between it and placebo. So the take-home message with Zyprexa is that the patient doesn't respond at the lower doses. It doesn't do you any good to keep titrating the medications. You're only going to increase the prevalence of side effects. You're not going to increase the likelihood of mortality, right? So more is not better when it comes to olanzapine. Again, when you look at side effect profiles, again, well, the higher you go up on the dose, the more side effects you get. Right? The more falls, the more somnolence, the more abnormal gait, Parkinsonism types. Okay, so then we'll talk about aripiprazole, which is Abilify. So it's interesting with, you know, 5 years ago, there was a perception in the community that Seroquel or just quetiapine was kind of the kinder, gentler antipsychotic, right? And so among the primary care community, if they were going to prescribe an antipsychotic, they would always go with Seroquel. There's always Seroquel, which again is quetiapine. That maybe it has fewer side effects, maybe. Right now, it's aripiprazole. Abilify is now perceived to be the kinder, gentler antipsychotic. It's just amazing how many patients we have come into our clinic who are on Abilify. So much of the nursing home psychiatric care in San Antonio is provided by nurse practitioners. Like almost all of it is provided by advanced nurse practitioners who are supervised by neurology groups in Houston, in fact. And so it's just like, let's try Abilify. Sometimes maybe it does. Okay, so if you look at the aripiprazole data, again you'll see that there is statistical separation and benefit. Maybe not that much. Again, that NPI is a 12-point scale, and there's really only about a 1-point difference between it and the placebo. So statistical improvement, or maybe not real improvement. And when you look at side effects, not surprisingly, there's more side effects in the treatment group. But what I really want to draw your attention to is strokes. So in the placebo group, there's no strokes. If you're 2 milligrams of aripiprazole, there was 1 stroke. If you go up to 5, well, 2 of them had strokes. If you go up to 10 milligrams, 4 of them have strokes. There's clearly more strokes associated in the treatment. So, kind of going back to your question, so the NIH, which is the government entity that sponsors investigator-initiated research protocols, the NIH decided, you know what, let's go ahead and try and answer this question once and for all. Is there any benefit? Is there any real benefit to antipsychotics for dementia? And so the NIH then designed this incredibly comprehensive study to try and answer this question. Do these medications help or don't help? And so they targeted an ambulatory sample. So this isn't done in nursing home patients now. It's done in ambulatory patients coming in and out of the clinics. And so they randomly assigned 420 patients to olanzapine, quetiapine, or risperidone, or placebo. And the plan was to have 6 follow-up appointments for 36 weeks. So speaking to your point, they said, look, what do we really know? 12 weeks, that's only 3 months. We need more data. We need to see if more time shows a better profile. So the NIH wanted a 36-week study. That's what they wanted. They wanted more data. The other way they were going to improve the study was they were going to have multiple outcome measures. So maybe the NPI is not the best measure. Let's find out if antipsychotic therapy, let's put a caregiver burden assessment in there to see if these medications reduce caregiver burden. Let's see if they improve quality of life. Let's see if they improve cognition. Let's see if they, whatever. Maybe there's something there that we're just not sensitive to, that we're not measuring. So they subjected the patients to this incredible battery of questionnaires, this probe for potential benefits. The average age was 77, over half were female, and 80% of the sample dropped out before 36 weeks, right? So the NIH said, my God, we're not any better. So even they had to only restrict it to 12 weeks. 80% of their sample dropped out. The dropout rates are enormous in these studies. So the NIH wasn't able to pull it off either. And I'm not going to drag you through all of this, because what all of this says is there was maybe minor benefit between the antipsychotics and the placebo. But the benefit, as you can see here, these are the antipsychotics clustered here. The agitation is certainly going down for all of them. There doesn't appear to be any difference between any of them. They're better than placebo, but the scale is still relatively small. The scale of change is small. So most people, when they look at the Katie study, most people view it as a negative study. They weren't able to find any benefits for these medications. And there was no difference in any other outcome measures. No difference in quality of life, caregiver burden, or anything else. So now we get to the heart of the problem here, which is that if we go back to death. So again, in all of these studies, the mortality rate in the treatment group is always about 4%. The mortality rate in the placebo group is always about 2%. So one way to interpret these numbers is that, well, 4% is twice 2%, so the treatment are twice as likely to kill you. Right? It's as easy as that. These medications are twice as likely to kill you. The problem, though, is that these medications is that the mortality rates are still small, right? It's still 4%, 2%. So is that really the best way to interpret the data? The better way is to use the numbers to calculate what's called number needed to harm. And when you do that, the number needed to harm is 50. So what this means is that for every 50 elders that are prescribed an antipsychotic for dementia-related behavioral disturbances, one will die, and it's because of the drug. One will die, and it's because of the drug. So now, I always tell people, it becomes existential, right? Now it's, what is your relationship with death? And if you have a good relationship with death, you're thinking, well, 1 in 50, that's not so much. I like those odds. But if you have a bad relationship with death, you're thinking 1 in 50, that's a lot, right? You know, how many elders with dementia does your typical geriatric internist treat in a month, right? At least 50, right? And so, again, you know, to answer the question at the beginning, you know, the question that I always get is, how come you don't just put them on, whatever, Zyprexa, just, you know, well, this is why, you know. And so these medications are now, they're black boxed by the FDA for use in dementia. That's why when you see them advertised on television, so for example, if Abilify is being advertised on television for use in bipolar disorder, you'll always see a disclaimer at the bottom that says, Abilify is not approved for use in dementia. You'll always see this disclaimer at the bottom of the ad. It has a black box warning. So when the black box warning came out, what that did was it really made a lot of the primary care doctors super anxious about prescribing these medications, because they're now black box. It's like, We know that there's risk. And so from a risk management perspective, it made a lot of them nervous. Now I can tell you that we do prescribe these medications in my clinic for dementia-related behavioral disturbances. I pulled the data just to learn what I knew. In 2011, so in 2011 we saw 168 patients in our clinic. The average age in my clinic is 74. About 40% of them have a dementia diagnosis. And of those with a dementia diagnosis, 1 in 4 is on an antipsychotic for dementia-related behavioral disturbances. So we actually do, so a quarter of my dementia cases are, their behavioral problems are managed with antipsychotic. Again, when we prescribe these medications, we're informing the families about the potential risks and benefits, and we don't prescribe them unless the situation is so bad that we're willing to tolerate a 1 in 50 chance that we're going to kill the person that we're trying to treat.
Is it actually helping with the behaviors, or is it just sedating them from the behaviors?
Yeah, what's the difference?
Yeah.
And I can tell you my take on it. No, I mean, my take on it, whenever I prescribe medications like this for anything like that, is, the conversation I always have with patients is, look, these medications are intended to make you more functional. They're not intended to make you less functional. So if you become less functional, if you become overly sedated, then it means we've picked the wrong one, and you need to tell me so that we can try something.
So a lot of times that's, kind of the answer to what they need at that point. I mean, I'm not saying that it's good, but I'm saying that when we go into nursing homes, we see so many people on these, and if they're not doing anything but sedating them, is it really worth? Is that what should we be giving them these medicines?
You tell me. You tell me. I don't have an answer. You tell me. And so, I can just think of even recent cases. A case, Fire and I are working on where, so the situation when we use these medications, for example, is when, the person is so delusional, they're making threats against family members, they're taking trips to places to buy guns to kill the family member, they're jumping over walls, they're doing all of this stuff, and what we're trying to do is keep them in their homes so that they don't have to go to a locked nursing home. So it's situations like this where there's
In-locked nursing homes.
an emergency.
In-locked nursing homes that are on these medications. I mean, it's
Right.
just,
So then within locked nursing homes, then you can say, within some nursing homes, there's different levels of care. There's lesser restrictive levels of care. And so if these medications help keep someone in a lesser restrictive level of care, then maybe you can argue that that's helpful. If the medications allow that person to stay in the nursing home, you could argue that that's helpful. I tell you what family members hate is when they get the phone call from the nursing home saying, look, your dad is out of control. It's beyond our capability to care for him. You have a week to find a new place. Then it's like, oh, is there anything we can do? Well, maybe.
But the majority of the people in the larger facilities, though, are not what you described. And they're still on these medications.
right, that's exactly what
And I think it's more so because of the numbers, the volume of the patients that are there, and it's more controllable. If they're not walking around, if they're more passive, they're a lot easier for two staff to take care of.
That's true.
So it becomes really an ethical question.
Oh, it's a very ethical question. And now it's a legal question. So speaking to your point, I forget when it was done, but there was a government survey of nursing homes where they found that, it was like 80% of the patients were on Haldol. It was a huge number that were on Haldol, which then prompted legislation to, change the pharmacy laws where these medications have to be better evaluated. But clearly it hadn't changed the problem. So I always tell what I always tell my students and residents is that, any idiot can start a medication. Right? I mean, I do it every day, right? So, so anyone can, so easy to start a medication. What it really takes a thinking person to do is know when to stop the medication, right? And I'm not here what you're saying. You're right. I mean, medications get started. They may have been helpful at the time, 6 years ago, but they were never stopped. We don't know if it has any value. Yeah, absolutely.
And also too, what are the other alternatives? Because I think a lot of things, we medicate, we'll put them on a medication because that's all we can really do. You don't have any type of alternative choices that you can make for that particular client that would be more helpful. Because you really, a lot of times, don't have the time. And the caregivers, on the other hand, when they're at home, may need some services that will come in to give them some type of a respite or reprieve. And sometimes that's all that might be needed. But I think so often we're very quickly bent on there has to be that pill. And from when we're this high, if we've got a runny nose, we want the pill. And so I believe that we're such in that way that's what we consider first.
Yeah,
It's become a
absolutely.
cultural thing
Absolutely.
too, because, in our society, that's how we care for elderly, is we put them in large groups and nursing homes and pay people to take care of them.
Well, and
not
medically
every
focused
right, and not
facilities,
every
too.
society does that, and so it's just all we know.
Yeah, well, I mean,
System
there are
we have.
more demented people not living in nursing homes than are in nursing homes. I mean, that's true. I mean, there is more. I don't know what the percent is, but it's actually a smaller percent that's in nursing homes.
It's only about 5 or 6% of those over the age of 70.
Yeah,
75
yeah.
years.
So it's a smaller percent, but it lends to this selection bias, which I think really might.
Luckily, the regulations have changed. I mean, it's kind of hard. It's a toss-up. I started in nursing homes back in '91 when Mellaril and Haldol were the answer to everything. Everybody got a shot. If you acted up, if you disrobed, it was just horrific. And you did reality orientation. It was a different world. It's changed in the last 10 years, fortunately, but there's a lot of regulation on restraining and psychotropic meds. There's a lot of documentation. So luckily, it's improved. It's just not where it needs to be yet.
Oh, sure.
But it's improved a lot.
Yeah. So let's see here. So kind of going back to what we know and what we don't know about these medications. What we know is that there's no FDA indication or any medication for this problem, right? We know that. We know that the off-label use of prescribing these medications is common, right? I showed you that, in my clinic, it's a quarter of the demented patients, which is again, there's a lot of selection bias there for who ends up in my clinic. But within that Cache County study, about 15%, 20% were on psychotropic medications. We know that there's more data for antipsychotics than for any other class. We know that within antipsychotics, there's more data for Risperidone than for any other antipsychotic medication. It's just, you can just count and see that. The studies show a modest efficacy, but the placebo rate is high. It's always 30 to 40% is the placebo response to the placebo response for agitations, about 30%. We know that these medications increase the risk of mortality and stroke. Again, about 1 in 50 will have a stroke, and 1 in 50 will have will die as a result of being on the medications.
I'm gonna say this is something I apologize in front of you. Our mortality rate is 100%. We're going to die.
Yeah, no.
I mean, that's just a fact. Why, if we know that this stuff doesn't work, why are we treating people like rabbits? And I mean, I hate to say that ugly because you're telling us it doesn't work. The very studies are showing it's not.
Well,
So what are we
but
doing?
sometimes it
Are we
does,
band-aiding it?
right? So, no. So sometimes it does work. So the problem with the studies is that they're all about the mean. But there are patients who clearly benefit from these medications. And we know they clearly benefit because when we stop them, all sorts of help breaks loose. So we know that these medications help some people. We're just not able to figure out who. We're not able to figure out, what are the biomarkers suggesting a response in elders with dementia. We don't know that yet. So we try different things. And if we get a clear benefit clinically, then we keep with it, and then we reevaluate it. If we don't get a clear benefit, then we stop, right? We stop.
So how do you come up with the quality of life when you're supposed to obviously do more than medication within a lot? You stick to the nursing home and then you keep sedated because you don't want to bother staff. I don't mean that. That's, I've been in nursing homes.
Again, a lot of times we really aren't sticking them in nursing homes. A lot of these patients are at home. Most of them, in fact, are at home. And what we're doing is we're working with the families. And that's what we're doing. We're working with the families to understand what their expectations are, what their levels of tolerance are. That's what we're doing. Yeah.
Because we see our elderly living longer in the later years into their 90s and hundreds, are there any studies on what these medications, on the effects of, because of their other body parts because of their age, not shutting down but deteriorating in some form or fashion? Are there any studies to be done on maybe the older generations of people with taking these medications?
It's kind of the old.
The old.
I don't know that anyone has looked at, because there are studies in what are called the old.
Yes.
The old is 85 and above. Typically, that's how studies will distinguish. They'll distinguish between the young old and the old. And so, I make it old. So I'm not aware of any studies that have broken those groups.
And I'm only asking because as we see, we're going to have this silver tsunami come in amongst us, and as we are being in better health and things like this, is there, I just didn't know if maybe there was a study.
Not that I'm aware of, not where they've broken up like that.
What is the perfect scenario for a study?
What do you mean?
What's the perfect scenario that it would take in your head, like on a perfect day, for a study for this, for all of these different types of drugs?
If there's a 100% response rate and no side effects. Right? That would be perfect, right? And so, but that's not what we have. Not even close. Not.
So how can you get closer with the studies since so many people drop off?
Right.
How can we?
I don't know. You're right. That's the problem. That's the problem. So when we prescribe these medications, what we're doing is we're following a palliative. We transition from a treatment model of care to a palliative model, is what we're doing, right? So these medications, the antipsychotics, or any of the others for that matter, we're no longer trying to treat the person per se. We're not trying to extend their life or stamp out their plaques and tangles or whatever it is. We're now using them palliatively. So the same way that we use pain medications palliatively, what we're saying is that, look, this person is so delusional, they're so psychotic, they're so stressed out, they're so fearful of their care providers, their quality of life is just so poor that we're going to transition to a palliative model of care and see if these medications can reduce the agitation, the anxiety, the psychosis, the paranoia. We're going to try that. And that's the model of care that we're following. So they're used in a palliative way. It's not about, the focus isn't on extension of life, it's on quality of life. And if the medications do not improve quality of life, we start it, there's no benefit, well then we stop it. We try something.
Is there any significance of it with male female?
No. so let's see here. We talked about that. Okay, so there's lots that we don't know. So we don't know individual medication differences. We don't know the risk of stroke and death beyond the 8 to 12 weeks of the studies. So we don't know that. As we were saying before, we don't know the risk factors or the protective factors. So we don't know the biomarkers for which someone might have that would suggest they're going to respond to the medications, or at least not have these terminal side effects. We don't really know the efficacy and safety of treatment alternatives, including psychosocial interventions. So we don't really know, how much, Risperidone versus music therapy has never been done, right? Randomize someone to Risperidone, pet therapy, or placebo, and see who wins. That study hasn't been done. Yeah.
And you know what, there are other types of settings also, other than a nursing home setting, that could be looked at. Because, in a larger setting, you are gonna probably have a particular, it may not be as conducive for that particular individual to, or get the best, it may not be the best environment.
Yeah.
And so looking at those same set of behaviors in a smaller setting with those types of music versus,
Sure.
pet therapy versus medications might bring a lot different results.
We could,
And there's money.
but we just don't know.
Who's gonna pay for it?
Can't patent pet therapy. So. Right, so that would have to be, government funded, right? Okay, let's see here. So again, we kind of look at this. So these are the recommendations from the College of Psychopharmacology. The first recommendation is to determine and treat if there's the etiology of the agitation. So if someone has a urinary tract infection, let's treat that. Let's don't just throw them on. It's recognized that just good routine clinical care may be as helpful as evidenced by the placebo response rate, right? So there's a 30% response rate if you're on placebo, suggesting that just coming to the doctor for regular appointments, and that has value in and of itself. We know that clinicians have to make decisions based on patients' and families' values regarding quality of life goals. And again, when we start prescribing these medications, it's all about quality of life, quality of life, quality of life. We identify the symptoms that we're targeting, we establish a time frame, and if the medication isn't working, then we stop and we move on, right? So we don't just put someone on something and then they're on it forever, right? That's not what we want. I will say also, though, anecdotally, that if we do find a medication that's helpful, I personally like to keep them on that medication for a year before we taper and discontinue. It seems like any time if they get a good response, if we take it off in less than a year, the symptoms almost all disappear. So I like to wait at least a year before we evaluate the med. We use the lowest doses, the shortest period of time necessary. To me, it has to be a year. Monitor the effectiveness, talk with families, monitor safety, look at their blood pressure, their weight, making sure nothing's going wrong there. We're educating patients and caregivers, switch if it's not working, coordinate with other health professionals to minimize the risk of treatment. These are the strategies that we use. So that's a lot. So yeah, I mean the data is it's hard with these medications because you just see data after data after data. They don't work. They don't work. They don't work. They don't work until they work, and then they work. It's like, wow, this really worked. And so we just keep trying. But it's certainly a lot of just kind of feeling our way in the dark.
Has there been any studies that show a combination, like maybe low dose combinations or something like that? When you were talking about that, all I could think of was, okay, if it's acting a little like bipolar, you got your paranoia over here, you've got all of these different behaviors, and you take all those medications and just kind of put them in a,
Yeah.
you know, and maybe make one pill.
Yeah.
That, you know, I don't know, I mean, that may be really unrealistic, and I know that there'll probably be some side effects and all of that kind of stuff to that, but,
Called ADH, Joe.
yeah.
So the problem, it's always better to be on a high dose, it's always safer to be on a high dose of one medication than it is to be on a low dose of a bunch of medications. That's just a known truism. The other thing though with these studies, you know, the big class of medications that I didn't show you any data on, because there have been no studies, is with anxiolytics, like Xanax and Ativan and Clomid. And I mean, those studies just haven't been done. And in a lot of these studies, those medications were embedded within the study as a PRN. So they would be randomized to risperidone or placebo, but their care provider could give them a PRN dose of Ativan, right? And so it just kind of muddies the water, you know, even more. You know, what I can tell you in my clinic, the way we do things after going through the treatment, you know, trying to find the causes, and, you know, when we start pharmacotherapy, you know, what we do is we always start with an SSRI, right? We start with an SSRI because, mostly because the side effect profile is the most favorable, not because they work better, but because it's less likely to do harm, right? So we always start with an SSRI. If the SSRI isn't working, then we'll augment with a benzodiazepine, like clonazepam or lorazepam, Ativan, or clonazepam, say. And if that's not working, then we'll go to an antipsychotic after talking with them. But we also don't chase every symptom. You know, if I have a patient who comes in and they're having, you know, visual hallucinations of little people walking across the mantle,
It's not bothering anybody.
it's not bothering anybody, if it's not impairing their quality of life, well then we don't even treat it at all. We just say, well, you know, just redirect them, tell them, you know, their eyes are playing tricks on them here, whatever it is. But we don't treat that at all, right? You know, the behaviors that are treated are the dangerous behaviors. It's when they see, you know, it's when they start chasing the hallucinations with knives, or they're running out into the street because they're scared, or, you know, whatever it is like that. So it's when the situation becomes dangerous that we treat.
What do you think about the double number like Dementia and Aricept or Dementia and Exxon? I see a lot of that.
Yeah. So the question is what about using the acetylcholinesterase inhibitor, Exelon or Aricept, whatever it is, and Dementia at the same time? Because they work differently, then that's fine, right? They work differently. They're operating on two different mechanisms of action, right? One is increasing acetylcholine, the other is preventing too much calcium from entering the nerve cell. And in fact, they've done those studies where they combine them and they show additive benefit. They do show additive benefit. And so that's okay. Yeah, that's fine. What I don't like seeing is when someone's on two of the same. They're on Aricept in the morning and Exelon at night. Like, that doesn't make sense. You know, it's better to be on a lot of one versus a little bit of a bunch.
Could you just talk briefly about the patient's behavior that manifests itself in hearing voices? What category was that under?
Hallucinations. So that's a hallucination. Yeah, seeing things that aren't there, hearing things that aren't there, smelling things that aren't there, feeling things crawling on your skin. Yeah. Those are all hallucinations. Yeah, those are hallucinations. And delusions are fixed, false thoughts. People are watching me, following me, stealing my things. You know, my daughter keeps stealing my stuff. There's people in the attic, and it just won't go away. That's a delusion. All right, well, break time?
Yeah, I want everybody to stand up. Stand up, everybody. Let's take a 10-minute break. Walk around, some blood in your brain. Oxygen. 10 minutes. That's 35 after.
Suitcase of memories. Time after, sometimes you picture me. I'm walking too far ahead. You're calling to me. I can't hear what you said. You said it goes slow. I'm far behind. Second hand